All right, I'd now like to welcome our first presenter for the evening, Tracy Palomino, a pharmacy student from Texas Tech University.
Good afternoon, everyone. Today I will be presenting atezolizumab plus bevacizumab as frontline agents for advanced hepatocellular carcinoma. So our learning objectives for today are to outline risk factors, prevalence, incidence, and various stages of hepatocellular carcinoma, to explain the mechanism of action of these two drugs, including possible synergistic effects, and to analyze the efficacy of combination therapy versus standard of care treatments. And finally, to evaluate the impact of combination therapy in a patient reported side effects versus the standard of care treatment. So now we go into our background. Next slide, please. So hepatocellular carcinoma is a type of cancer that arises from hepatocytes. It's also the most common form of liver cancer. It's the fourth leading cause of cancer mortality worldwide, with a 5-year survival rate of 18%. In the US, liver cancer mortality has increased by 43% from 2000 to 2016. Next slide, please. So here we have the incidence. In 2021, an estimated of roughly 42,000 people will be diagnosed with liver cancer in the US. This encompasses about 2.2% of all new cancers, and approximately is 3 times higher in men than women. Here I have a diagram of the digestive system cancers. You can see both sexes here, then males and females, and they're color-coded for their different incidence percentages. Next slide, please. Now we go into prevalence. So I use the Surveillance Epidemiology and End Results program, which evaluated 13 different areas across the US. And this is from 2018. It showed that about 66,000 people, men, and about 30,000 women were affected. Also show about 56,000 of those were 65 and older. And I have 2 diagrams here that show you the prevalence. You can see here it affects mostly our elderly population and also males. Next slide, please. So our risk factors, what are our risk factors? We have cirrhosis and without cirrhosis. For cirrhosis, we have several different risk factors, such as hepatitis B and C, alcohol, which has a 2-fold increase, and genetic hemochromatosis, non-alcoholic fatty liver disease, stage 4 primary biliary cirrhosis, and alpha-1 antitrypsin deficiency, and as well any other causes of cirrhosis. For without cirrhosis, we have hepatitis B carriers. And I have included here the US standard drink. Here's the picture. Can you click the slide? There's an animation after that. So how many drinks are too many? Next slide, please. So by the National Institute of Alcohol Abuse and Alcoholism, it says that anything greater or equal to 4 drinks in men, or anything for greater or equal to 3 in a woman on any day, will have a high risk of alcoholism. So for men, no more than 14 drinks in a week, and for women, no more than 7 drinks in a week. Some questionnaires that aid the diagnosis are the audit questionnaire, which scores by points, and anything greater or equal to 8 points for men, and anything greater or equal to 4 for women. You also have the CAGE questionnaire, and this one is anything greater or equal to 2 points. Next slide, please. So here for our signs and symptoms, keep in mind that the signs and symptoms you're going to see at the as the disease progresses. So it comes in later on the disease. For signs, we have hepatomegaly and ascites. And for symptoms, we have hepatic jaundice, anorexia, weight loss, malaise, and upper abdominal pain. Next slide, please. So how is it diagnosed? It's diagnosed mainly through imaging. They use the abdominal pelvic CT and also contrast MRI. Some biomarkers see if there's a risk for HCC is the serum alpha fetoprotein. However, it's non-sensitive or specific. So biopsy is rarely used, and it would only be used when the suspected lesion doesn't meet imaging criteria, or the patient is not considered high risk for HCC, or if the patient presents with non-malignant nodules. Also, if the patient has an elevated carcinoembryonic antigen, which is also a biomarker. And finally, if there is any history of another primary malignancy. Next slide, please. So now we go into staging. So the Barcelona liver cancer staging is widely used. However, the National Comprehensive Cancer Network recommends the use of the Child-Pugh score and the TNM staging system. So here I have a table of the Barcelona Clinic liver cancer staging. So it basically breaks it down into early and intermediate. You have your stage 0 to A and stage B. And you have the advanced HCC, stage C, and stage D. Stage D is end-stage liver function as well. For the standard of care treatment, as the disease progresses, we have different treatments. So first, you will use ablation, resection, and transplantation. Next, we have chemoembolization, TACE, abbreviated, and systemic therapy. And finally, we go to best supportive care. Next slide, please. So the Child-Pugh score, it score points for increasing abnormality. It also looks at different chemical and biochemical parameters. And in this case, we use it to know if the patient will have a good operative risk or a poor operative risk or moderate. It has different classes, class A, B, and C, which we want to mainly be in the class A because we'll have a better outcome. Next slide, please. So now we have the TNM staging. So the TNM staging grades the tumor by the primary tumor, and it has different sizes as it goes into the progression of the tumor. And the N stands for regional lymph nodes, and M stands for distant metastases. So if you have an M0, there is no distant metastases, versus M1, where it has a distant metastases. Additionally, the American Joint Committee on Cancer has separated the TNM system into stages. So you have stage 1 through stage 4. And I've highlighted here the stage 3 to 4 as the most advanced type of cancer. This fails to account for liver function and no prognosis for HCC patients, but it doesn't impact survival. Next slide, please. So now we go into our mechanism of action. Next slide, please. We have atezolizumab and bevacizumab. So I'll start with atezolizumab. Atezolizumab is a humanized monoclonal antibody immune checkpoint inhibitor that binds to the programmed death ligand, PD-L1. By doing so, it prevents the interaction with the programmed cell death, PD-1, and B7, also known as CD8 receptors. This promotes T-cell activation. For bevacizumab, it's a recombinant humanized monoclonal antibody binds and it neutralizes the vascular endothelial growth factor, VEGF, and blocks angiogenesis. And by doing this, it increases T cell filtration. Next slide, please. So now we go into understanding the synergistic effects. So HCC is a hypervascular type of tumor that is driven by growth factors to achieve angiogenesis, leading to growth, tumor, and metastases. So how does VEGF play a role in the immune system evasion? It decreases T cell activation via inhibition of the dendritic cell maturation. It decreases T cell tumor filtration and increases inhibitory cells such as the myeloid-derived suppressor cells and regulatory T cells in the tumor microenvironment. What about PD-L1? PD-L1 expression leads to anti-tumor immunity suppression on T cells. It inhibits proliferation and effector function of T cells. So the proposed mechanism is that PD-L1 and VEGF inhibition may be effective in reducing HCC by producing a more immune favorable environment, thereby enhancing anti-cancer immunity. Can you click, please? So the question is combination therapy more effective in advanced HCC than the standard treatment? So we go into our trial that got FDA. Slide, please. So I Am Brave was an open label randomized phase 3 trial. Here I have outlined the eligibility criteria, stratification criteria, and the patients that receive therapy. For eligibility criteria, we have a locally advanced metastatic and unresectable HCC or both. Patients were greater or equal to 18 years old, had an ECOG status performance of 0 to 1, which the ECOG status, you want to have a lower number here because as you go up into the numbers, you have a lower performance status, and it goes from 0 to 5, and 5 indicates death. They also had no prior systemic therapy, no bleeding or high risk of bleeding. And patients had a Child-Pugh class of A. The stratification criteria was based on the region, ECOG status, presence or absence of microvascular invasion and extrahepatic spread, as well as the alpha-fetoprotein I talked about earlier. They were randomized 2 to 1 to receive the combination therapy atezolizumab plus bevacizumab or sorafenib, which was the standard of care treatment at the time. They were also analyzed up to prior loss of clinical benefit or unacceptable toxicity. The tumors were assessed by tomography or MRI. They also looked at the adverse effects using the National Cancer Institute common terminology criteria for adverse events, and the sponsors of the trial were the manufacturers of the drug. For the exclusion, we have history of autoimmune disease, co-infection with hepatitis B and C, untreated esophageal varices or gastric varices that could lead to high risk of bleeding or any type of high risk bleeding. Also, prior allogenic stem cell or solid organ transplantation, and history of hepatic encephalopathy. Next slide, please. So here we have our outcomes. Our co-primary outcomes were to assess overall survival and then to assess performance, progression-free survival, and our secondary outcomes was to assess objective response rate and duration of response. Additionally, they assessed deterioration of quality of life, physical, and role functioning. For our safety outcomes was to evaluate the incidence of and severity of side effects. Next slide, please. So the statistical analysis they performed their stratified log rank test, which I think is appropriate for this type of study. And the stratified Cox proportional hazards model, which was trying to find the hazard ratio and that estimate, is also appropriate. And the Kaplan-Meier analysis curve that assesses for survival. The Coupler-Person method was also used to assess the objective response rate. And the unadjusted Fisher-Exact test was used as well. Then they also used the stratified Cochran-Mental-Hansel test, which this test analyzes for stratified or matched categorical data, which is also appropriate in this type of setting. Next slide, please. Next, we have our patient characteristics. Patients were median age of 64, 66, which was relatively the same. Most patients were males. Both groups were roughly the same percentages, and they had a Child-Pugh class of A, and the BCLC staging was mainly class C, which it corresponds to the advanced HCC. Next slide, please. Next, we have our other characteristics. We have the alpha fetoprotein greater or equal to 400, extrahepatic spread, macrovascular invasion, or both, and patients who received prior TACE. They were also very similar for both groups. Next slide, please. And here I have the median overall survival, which could not be evaluated for the combination therapy. And this means that the patients were still responding to the treatment versus sorafenib, which showed 13.2 months. Additionally, the progression-free survival for the combination therapy was 6.8 versus 4.3 months. So combination therapy again performed better than sorafenib. Next slide, please. Here I have outlined the objective response rate, which also accounts for the complete response and the partial response. That percentage is higher than sorafenib. As well for was used to evaluate the HCC as a vascular tumor. So they modified the RECIST criteria, which RECIST is used to evaluate solid tumors. Next slide, please. Here we have our quality of life median time to deterioration. As we can see with the blue line, the combination therapy performed much better than sorafenib. Next slide, please. And here we have our physical functioning median time to deterioration. Again, we can see a greater response with the combination therapy. Next slide, please. And here we have our role functioning median time to deterioration. Again, the combination therapy performed better than sorafenib. Next slide, please. So here I have the adverse events with the combination therapy and sorafenib. So they're both similar to each other. You have 92.8 for combination, sorafenib 98.7. Adverse events, anything greater, any grade 3 or 4, 5.6% versus 55%, sorry. Again, they were very similar. The adverse events leading to this, I'm sorry, this box is supposed to be on the last. Adverse events with incidence of greater than 10%, grade 3 or 4 were hypertension, and sorafenib also had hypertension, which shows that the patients were getting the same or adverse events with the combination therapy and the current standard of care at the time. Next slide, please. So conclusions for this trial is that it demonstrated a statistically significant improvement in overall survival and progression-free survival with atezolizumab plus bevacizumab, then sorafenib. Also, response rates were statistically significantly higher for the combination therapy. Serious toxic events were higher in patients who received the combination therapy, but no new or unexpected toxic effects were detected. Additionally, the combination therapy showed a longer time to deterioration on patient-reported quality of life and functioning than sorafenib. Next slide, please. So final thoughts. The strengths of the trial are the open label study design, which spared patients from receiving placebo, which is unethical in this case, and patients were greater than 60 years old and males. It corresponded to the the prevalence of the disease in those greater than 60 years old and mostly males, as well as the high-risk patients were included with macrovascular invasion and extrahepatic spread. Additionally, they assessed quality of life and the use of sorafenib as the control arm, which was the standard of care at the time. Weaknesses of the trial are that the trial majority of patients were class A, therefore the safety of the combination therapy in a broader population needs further research. They also excluded patients with co-infection of hepatitis B and C. Next slide, please. Next slide, please. So a follow-up trial to evaluate the patient-related outcomes from IAMBRAVE 150 was conducted. They looked at the combination therapy and they found that it reduced the risk of deterioration based on the European Organization for Research and Treatment of Cancer questionnaire. And they saw a decrease when using the combination therapy on appetite loss, diarrhea, fatigue, and pain. So clinical benefits were seen in patient-related outcomes when using combination therapy, and therefore less patient burden is seen when compared to sorafenib. Next slide, please. So here I have the cost of the medications. We have atezolizumab, $568. We have bevacizumab, $239, and sorafenib at $207. So if you consider a male patient that weighs 170 pounds, I calculated that the combination therapy for a year, it would be costing around $400,000 versus sorafenib costing $151,000 for a year's supply. Next slide, please. The clinical application of IAMBRAVE, the clinical application is that IAMBRAVE led to the FDA approval of combination therapy for advanced HCC. Atezolizumab plus bevacizumab is approved as the preferred first-line agent in advanced HCC. And overall, the studies have demonstrated higher survival rates in patients who were treated with the combination therapy and in comparison with sorafenib. In patients with no prior systemic therapy, combination therapy is preferred. And our future perspectives, I have these two studies that are in progress right now in China. Their first one is a randomized, open-label, multi-center phase 3 to evaluate the safety and efficacy of toripalimab combined with bevacizumab versus sorafenib as first-line therapy for advanced HCC. So toripalimab is a recombinant humanized programmed death receptor monoclonal antibody that binds to PD-1 and prevents binding of PD-1 with the program dead ligand. Next one, we have the randomized placebo-controlled double-blind multi-center phase 3 to compare toripalimab combined with lenvatinib versus placebo combined with lenvatinib as first line for advanced HCC. Lenvatinib is a multi-target tyrosine kinase inhibitor of VEGF receptors, fibroblast growth factor receptors, platelet-derived growth factor receptors, and different kinases as well. Next slide, please. So I would like to thank my mentor, Dr. Christopher Stelby, and Dr. Chelsea Kruger, and Dr. Austin Starkey for helping me with the presentation. And thank you for listening. Do you guys have any questions for me?
All right. If anybody has any questions, feel free to utilize the chat box as well. But just due to the interest of time, we will go ahead and move on with our next presentation to kind of highlight another indication for atezolizumab. So now I'd like to turn it over to Heather Freeborn.
Hello, everybody. I'm going to share my screen so that I can, let's see here, PowerPoint. And I'm going to do slideshow, play from start. All right, can everybody see this? If you cannot see this, please let me know. Additionally, let's see here.
Is
Oh,
there a way to make it bigger?
You can see the notes and not the slideshow, is that right?
It's really small.
Yeah, I'm going to fix this. You can see the notes and not the slideshow, which is swap displays. How's that?
Heather, you might have to re-hit share screen and then try it again from there.
Okay. I'm going to end this. And then I'm going to go to the set up slideshow, custom show, presenter view. Let's try this again. What are you seeing? Are you seeing the slide are you seeing the big slide, or are you seeing my notes?
On mine, I see it looks like it's trying to pull up, but it could just be my internet lagging slightly behind, but it does look like we do see the slide.
Okay, so it's taking up the entire screen. It should.
No, it's not, Heather.
Okay, I'm good. Should I stop sharing this and you run it?
Yeah, I can do
Yeah?
that. Just give me
Okay.
a second.
Okay. I'm going to end this and I'm going to stop sharing. Sorry, everybody.
I will be there in just a second.
Mm-hmm. I'll tell you about myself. So my name is Heather Freeborn. I live in Seattle, Washington, and I work for Genentech. And you saw from my title that I'm a therapeutic area manager. That's what they call us now, not salespeople at Genentech. But basically, I work with the Tecentriq portfolio. So I work with all the lung cancer indications as well as the hepatocellular carcinoma. So that was a really nice segue into my talk. So thank you. I appreciate that, Tracy. You did a nice job. And I'm also a nurse. I've been a nurse for over 30 years, and
Oh, you're welcome.
and then I also did oncology nursing. In the last 15 years of my career, I've been in pharma. So I can see these slides. Is there a way to make the kind of take up the whole screen or bigger? There, perfect, thank you. Okay, so Lena, you'll see as I kind of go talk through these, you'll know when to advance. Okay, so I'm going to leave my screen on because I think just for me, I know I like looking at the person who's speaking. I find it engaging. So that's me, and I'm going to be giving you a talk about Tecentriq and carboplatin etoposide for extended stage first-line small cell lung cancer. And that is the first FDA-approved cancer immunotherapy combination in this patient population. It is a Category 1 preferred NCCN recommendation, which is the highest recommendation the NCCN gives. The indication you can see here that in combination with carboplatin and etoposide is for first-line treatment of adult patients with extensive stage small cell. Okay, I just told you who I am. I'm an employee. This is just to give you information about Tecentriq, and it's consistent with the FDA-approved messaging. So I'm not going to tell you anything that's off-label. Okay, this slide we're going to come back to. This is at the end of the slide deck as well, but just be sure that I'm going to talk to you about warnings and precautions. All right, so let's look at disease overview first. And I wanted to say if there's any questions along the way, please put it in the chat. Okay, so small cell lung cancer. This is a highly aggressive, lethal, and widely metastatic disease. It arises from the neuroendocrine cells that live in the mediastinum. They're basically there in utero that help our bodies grow when we're in utero, and they stay there. And then when these cells are exposed to something like a toxin of some kind, like cigarette smoke, and some of these people, it can be like lighting a match, and it really gets, these cells get inflamed and they start mutating and become cancer, small cell lung cancer. It accounts for 13% of all lung cancer cases. It used to be called oat cell carcinoma because it looked like a little piece of oatmeal, and it looks like a little piece of oatmeal on the slide. Most of the patients are aged 60 to 80 years old. And in contrast, non-small cell lung cancer is 85% of lung cancers. It's less aggressive than small cell lung cancer, and it's kind of more in the periphery, whereas the small cell lung cancer can be found more often than not in the mediastinum where it starts. So 30,000 cases in the US a year. 250,000 worldwide die from small cell lung cancer. Now, as far as the relative survival, as you can imagine, it's quite poor. About 6% of patients of all early and metastatic small cell lung cancer, only 6% reach 5 years survival. And you can see from this that about 60 to 70% of patients present in these advanced stages. Now, as far as staging goes, we all know that the AJCC has a staging system that goes from stages 1 through 4 for most all cancers. But this, we just go with a limited stage and extensive stage. So when it says ES-SCLC, it's the extensive stage lung cancer, small cell lung cancer. And like I said, about 60 to 70% of these patients will present at these advanced stages. Okay, so risk factors, I already talked to you about smoking. 98% of patients have a history of smoking. And there's secondhand smoke that can be involved, exposure to radon gas, personal family history of lung cancer, air pollution, and workplace carcinogens. So think about like firefighters that will come in exposed to asbestos and lots of other damaging things that they run into during work. Okay, so the next slide is all about symptoms, but what I want to say is that this can be a symptom of any lung cancer. It's not specifically small cell, it could be any lung cancer. And in addition to these, with small cell lung cancer, patients can develop a paraneoplastic syndrome, which means that they're having something go on in their body as a result of having cancer. And since these are neuroendocrine cancers, for instance, they can have a low sodium form, SIADH, syndrome of inappropriate ADH, along with like these symptoms, like in the emergency room, for instance. Okay, keep going. So over the years, progress has been limited. The NCI calls it a recalcitrant cancer because it is so hard to find a good therapy for it. You can see here from the 1940s on, they tried to, like in the 1940s, a lot of tumors got treated with nitrogen mustard. And then they went on into the 1960s after doxorubicin was found to be somewhat beneficial in cancer. So then you're looking at anthracyclines, then you're combining them as time goes on with radiation therapy and surgery. Then you're moving on to the 80s and 90s with cisplatin and etoposide to have some benefit. And in the second line setting, you can get topotecan. And then in 2019, the FDA approved immunotherapy, which is atezolizumab or Tecentriq. So why is this so hard to treat? Well, I already talked about one of those factors, and that is lung cancer. Number one, lung cancer screening is not widely used, even though it's been approved and it's paid for by Medicare, and the recommendation is that certain people get screened for lung cancer. There's still only maybe 5% of eligible patients in the US that get screened. It's a fast-growing cancer. It's diagnosed at later stages. Sorry, Lena, I'm just kind of giving some extra info. Since this is a smoking disease, you're generally going to see patients have a feeling of personal shame about it and feel embarrassed. And they think that some smokers feel like they deserve it because they smoked. Also, almost all patients with small cell lung cancer have mutations that inactivate two key tumor suppressor genes, RB and TP53. So it's resistant, it's chemo resistant. Okay, so moving on, we've got, like I said, limited progress. More than 40 phase 3 trials evaluating other regimens in first line have been attempted since the 1970s, none of which have led to approvals until now. So we're going to talk about the clinical trial results from the Empower 133 study. Okay, so this included patients with extensive stage small cell lung cancer, randomized 1-to-1 to receive either Tecentriq and carboetopuside every 3 weeks times 4 versus placebo and carboetopuside. It was after that you had maintenance with the Tecentriq and placebo in the placebo arm, and these were both treated until disease progression or unacceptable toxicity. And I just wanted to say also it was a phase 3 multi-center randomized double-blind placebo-controlled trial with no prior chemo. And this, like I said, is extensive stage. All right, so moving on. You can see here that the two groups were well balanced, median age 64, with liver mets and brain, which is the two first places where small cell lung cancer will metastasize to. On the next slide, you'll see the results. So remember, 40 clinical trials in 20 years, no progress. And then with this combination, you've got a 30% reduction in the risk of death versus placebo plus chemo. So it's 12.3 months of median overall survival versus 10.3 months in the placebo arm. So you can see here from the Kaplan-Meier curve that it does not separate right away. It separates further down, and that's why in these immunotherapy trials, we focus more on the overall survival curve because we're going for those extended and deep responses. Okay, there was also another endpoint of PFS, which was 5.2 months versus 4.3 months. The overall response rate was very similar in both arms, you can see. Now, why is that? Well, this is any response of any patient in the study, okay? These patients respond to chemo. This is a fast-growing tumor, and they all respond to chemo. The problem is with small cell lung cancer is that it comes back right away and is deadly right away. Okay, so the additional survival data. So this is not powered to demonstrate statistically significant differences, but it is for your information that you can see with 2 years of follow-up that at 2 years, 22% of patients were still alive in the Tecentriq arm as opposed to 17%. Okay, so we're going to talk about immune-related adverse reactions. Actually, so I've talked about the efficacy, right? Now it's time to talk about safety. So efficacy and safety always have to be balanced, right? The risk benefit, how you talk to patients about these kinds of drugs and studies, et cetera, all needs to be weighed with the risk and benefit. So that's what I'm doing here in this presentation with you. I've told you the benefit, and now here's what happened with the patients as far as safety. Okay, so, and I'm going to talk to you about the mechanism of action and the immune system in just a minute. So this slide here talks about immune-related adverse reactions that are reported in greater than 1% of patients. And you can see there was more rash, hypothyroidism, hepatitis, infusion-related reactions, hyperthyroidism, pneumonitis, colitis, and we're going to go over a couple of these in more detail later. On the next slide, you can see these are not indicated as immune-related adverse reactions. These are adverse reactions, all of them, right? So you can see here that they have fatigue, asthenia, nausea, etc. So you can see a lot of these are due to chemo, right? So there's a similar representation in both arms. And down below it says it was Tecentriq was discontinued in 11% of patients. It was interrupted in 59%. Serious adverse reactions in 37%. The most frequent were pneumonia, neutropenia, febrile neutropenia, thrombocytopenia, and fatal were pneumonia, respiratory failure, neutropenia, and death. Okay, next slide. So laboratory abnormalities, I'm not going to read the slide, but you can see that there were definitely laboratory abnormalities in some grade 3 and 4 in both arms of the study, as well as on the next slide. You can see that there were laboratory abnormalities as some grade 3 and 4, both arms. Okay, I'm going to talk more about side effects in just a minute, but we're going to move on and talk about how to prepare. So it comes in this sterile preservative-free colorless, slightly yellow solution for IV infusion. It comes in 840 milligrams per 14 mils or 1200 milligrams per 20 mils. So first step, inspect. Next step, withdraw. Keep going. Third step, we're going to mix it up. Do not shake it. Gentle inversion. Okay, next step, store or discard. It's important to know that you can store it at room temperature for 6 hours and refrigerated for 24 hours and no more. So that means you don't mix the drug until the patient's sitting in the chair in front of you and you know it's a go, right? It might save time to make it ahead of time, but if you end up wasting that dose, it's a lot of money. And that's just a good practice that I've heard from lots of pharmacists. Okay, so choose the Tecentriq infusion schedule that works for you. There's Q4 week dosing, Q3 week dosing, and Q2 week dosing. This is especially nice when the patient is on monotherapy, then they could come in every 4 weeks if they want to. So when you're giving it with chemo on that same day, give it first before the chemo. Don't give it as an IV push or bolus, and do not co-administer through the same line. Okay, so here's the summary. Increased survival demonstrated was 12.3 months versus 10.3 months Tecentriq versus placebo. The median PFS 5.2 months versus 4.3. Overall response rates was similar in both arms, and serious adverse reactions 37% receiving Tecentriq. Okay, so we're going to talk about some management, and actually this slide right here has a lot of words on it. Oh, keep going. But I think this is really important. There's a couple of important points I'm going to make. I'm not going to read this, but I just wanted to tell you the mechanism of action. So Tracy talked about the mechanism of action. She actually used some Genentech slides to show you the graphics. So that was really great. So basically, this is a PD-L1 inhibitor, right? So it goes around. Tecentriq is like a sponge that mops up the ligand, PD-L1. What does PD-L1 do? It stimulates the PD-1 receptor to hide the tumor cell from the T cell. So basically, it's like cloaked, and Tecentriq will come and remove that cloak so the T cell can do its job. Kind of simplistic, but this is what makes a T cell kill a cancer cell if you overcome this like resistance mutation, which is which is resistance mechanism, PD-L1, right? Okay, so because of this, the immune system is stimulated because you've got all these T cells looking at things with no PD-1 active, there, and they're starting to attack cells, like hopefully mostly tumor cells, right? But there are going to be some immune-related adverse events as a result of that. Any immunotherapy can cause any side effect at any time. It's just a good rule of thumb. Some people have multiple toxicities. So the key to all of this is finding the side effects early. Colitis used to be a terrible, deadly side effect with these immunotherapies until people knew to look for them early and treat them aggressively. They can affect any organ system or tissue. And like I said, anytime. So after the immunotherapy is stopped, you can have side effects. Okay, let's move on. So there's a few immune-mediated side effects that are good to point out. One of them is pneumonitis. Now, generally speaking, you're going to see more pneumonitis in the lung cancer patients, more hepatitis in the liver cancer patients. That makes sense, right? And these can be, relatively small, occurrences, whatever, 3%, 1%, but they do happen. And these are all reported based on all patients receiving Tecentriq. So 2,616 patients receiving Tecentriq. Out of those, 83 patients got pneumonitis. So it still happens. I have heard of it happening. It definitely, something you need to look out for. In general, the treatment of any immune-related side effect is going to be corticosteroid therapy, 1 to 2 milligrams per kilogram per day of prednisone or equivalent. Now, that's a pretty hefty dose, right? But you've got this active immune system here that's causing a pneumonitis, which can be lethal for a patient. So you really have to go in there in response. So that's what you're going to be doing. Now, that's just for grade 3s and 4s. So that's a general rule of thumb for these types of reactions. So you've got the pneumonitis. Now we go to colitis. Colitis is a thickening of the bowel mucosa, and it causes really terrible diarrhea. Grade 2 or 3 colitis can be treated also with steroids. Let's move on. As we're getting through these, you'll see that the rates are here. So the rate of how many patients got this. So this is 1.8% of patients with hepatitis with tumor involvement. And then the next one, let's see, did I do that right? Oh, I didn't do that. You know what? The first one was no tumor involvement, and then the next one was tumor involvement. Sorry, not keeping track very well. And then we're going to immune-mediated endocrinopathies. So adrenal insufficiency, 11 out of 2,616 patients. So it may seem rare, but chances are you'll see some of these if you work with immunotherapy. Then we're going on to immune-mediated hypophysitis, so inflammation of the pituitary gland. Did I say that right? Yes, I did. Okay, I'm paying attention. Okay, then we've got thyroid disorders. Keep going. And we've got more thyroid disorders. You can also get type 1 diabetes. It can present with diabetic ketoacidosis. And you can get immune-mediated nephritis with renal dysfunction, and then immune-mediated dermatologic adverse reactions. So these other ones may be treated with like an injectable steroid. This is topical corticosteroids. A lot of these patients, you're going to be withholding treatment, waiting until that side effect has gone down to like a grade 0 or 1 and maybe restarting. Just depends on what the provider is comfortable with, how the patient's doing, what the patient wants to do, how the disease is doing, all those various factors. And then at the end, there's information about myocarditis. So there's cardiovascular, nervous system issues, ocular issues. These are all rare. But the point is, you see something weird, you got to look for it. You got to look at it and take it seriously. You're going to be doing very careful patient interviews to find out, how they're feeling and looking at those labs very carefully. Okay, so keep going. This just talks about how to treat the cardiac and neurological toxicities. And then, of course, you can have infusion-related reactions because it's a monoclonal antibody, right? It's protein-derived, and that's 1.3% of patients. Next, we've got a slide on the complications of transplant after PD-1 inhibitors, which did not take place in this small cell cancer study, embryo-fetal toxicity, and nursing mother's fertility. So to sum it all up, the most common adverse reactions are fatigue, asthenia, nausea, alopecia, constipation, diarrhea, decreased appetite. Okay, so Genentech has a great support system for patients who need financial support, whether it be commercial insurance, public insurance, no insurance. Got a great copay card program that provides the patients would pay 5% copay for a Genentech oncology product with a benefit of $25,000 every 12 months per product. And those are accessible via this website, genentech-access.com, where you can look for assistance, patient financial assistance for any Genentech product. And it's really quite easy. It leads you right through it. So basically, that's the end of my presentation, but I just wanted to let you know that immunotherapies are rather new to oncology. And this is just the beginning, right? More indications to come. There's definitely new and different side effects from the chemotherapy to be aware of. And I think that if you all go into oncology pharmacy practices, you will be dealing with these a lot in the future. All right, so thank you. Any questions, discussion?
Thanks, Heather. Just as kind of a point of discussion, can you kind of discuss why this mechanism of action or this target's so unique, where atezolizumab, as we kind of heard tonight, can target both that lung cancer and that hepatocellular carcinoma?
Right. So PD-1 exists in anywhere there's a tumor going on, growing in the body. The tumor itself releases PD-1, PD-L1, the ligand. So that's one of its mechanisms of, surviving against T cells, which is the body's natural defense mechanism. So it works in things like breast cancer, hepatocellular, non-small cell lung cancer, small cell lung cancer. So that's why, because any tumor that's expressing PD-L1 may potentially be able to be treated with Tecentriq.
Thank you.
Mhm.
And everybody, I'd like to thank you all for joining us this evening. If there's no questions or if there's any follow-up questions, feel free to reach out and we'd be happy to address those as they come in. But thank you for your time this evening. And I'd just like to mention our next student educational talks will be happening at September 29th, again at 8 p.m. Eastern.